Hey everyone, and welcome to another deep dive. You know how much we love getting our hands on some cool research and really digging into it. Well, today we're tackling ventricular arrhythmias. And a huge thank you to the London HeartbeatsZ Academy in the UK for giving us the material for this one.
Glad to be here.
So basically, we're going to be figuring out how doctors can use those electrocardiograms, ECGs, to pinpoint exactly where in the ventricles those irregular heartbeats are coming from.
It's like detective work for the heart.
It really is. And just to give you a little taste of what we'll be uncovering, did you know that some arrhythmias actually happen in perfectly healthy hearts?
Yeah, those idiopathic arrhythmias, they can be a bit of a mystery.
And get this, the pattern on the ECG can actually tell us whether an arrhythmia is coming from the right ventricle or the left ventricle. Even specific structures within them. It's amazing.
The heart's electrical system is incredibly intricate.
Okay, so before we get lost in the world of ECG squiggles, let's start with the basics. What exactly are ventricular arrhythmias and why should we even care?
Well, ventricular arrhythmias, or VAs, for short, happen when the electrical signals that control your heartbeat get messed up in the ventricle.
Okay, so kind of like an electrical short circuit.
Exactly. And these messed up signals can lead to extra beats, a really fast rhythm, or even just totally chaotic electrical activity.
This is kind of scary.
Well, not all VAs are dangerous, but some can be life-threatening because they disrupt the heart's ability to pump blood effectively.
So it's not just about having an irregular heartbeat, but how that irregularity affects the heart's actual function.
Precisely. And that's why it's so crucial to figure out where these arrhythmias are coming from. If we can pinpoint the source, we can target the treatment much more effectively.
Makes sense. Now, you mentioned earlier that some arrhythmias can actually occur in healthy hearts.
Yeah, we call those idiopathic VAs.
Idiopathic VAs.
Yeah, and it's fascinating because even without any structural damage to the heart, these arrhythmias can still pop up.
So even a healthy heart can have its own little electrical quirks.
You could say that. But then on the other hand, we have arrhythmias that are caused by actual damage to the heart.
And those are a bit more serious, I imagine.
They can be. We call them structural heart disease-related VAs. And they're often linked to conditions like coronary artery disease, heart attacks, or heart muscle diseases.
So basically anything that disrupts the normal structure of the heart can create a breeding ground for those abnormal electrical signals.
Exactly.
Okay, so we've got those good hearts with their occasional electrical blips. And then we've got hearts with structural damage that can lead to more serious rhythm problems.
But where does the ECG fit into all of this? I mean, it's just a bunch of squiggly lines, right?
Those squiggly lines actually hold a wealth of information.
More than meets the eye.
Exactly. The ECG allows us to actually see those electrical signals as they travel through the heart.
You're kidding.
And by analyzing the patterns of those signals, we can not only diagnose the arrhythmia, but also pinpoint its origin within the ventricles.
So it's like a map that leads us right to the source of the problem. Precisely a GPS for the heart's electrical system.
That's incredible. And I'm guessing that information is crucial for deciding on the best treatment strategy.
Absolutely. Whether it's medication, an implantable defibrillator, or a procedure like catheter ablation, knowing the source of the arrhythmia helps us tailor the treatment to the individual patient.
Okay, so the ECG is the key to unlocking the mysteries of these ventricular arrhythmias. But let's go back to those idiopathic arrhythmias for a second. If the heart is structurally normal, how can doctors tell where those electrical glitches are coming from?
That's where the real detective work comes in. The ECG can distinguish between arrhythmias coming from different parts of the right ventricular outflow tract, or RVOT for short.
RVOT, got it. So we're talking about the pathway where blood exits the right ventricle on its way to the lungs.
Right. And the ECG can actually help us differentiate between an arrhythmia coming from the top part of the RVOT versus the bottom part.
Seriously, how does it do that?
By looking at the shape and timing of the QRS complex.
Okay, remind me what the QRS complex is again.
It's the main spike you see on the ECG tracing. It represents the electrical activity as it spreads through the ventricles.
Got it. So the shape of that spike can tell us where the signal is coming from.
Exactly. For instance, an arrhythmia coming from the septal side of the RVOT, which is closer to the wall that divides the ventricles, will look different on the ECG compared to one coming from the free wall, the outer part of the right ventricle.
So even a slight shift in the ECG pattern can point to a different location within the RVOT.
Precisely. And these patterns are surprisingly consistent, which allows cardiologists to make pretty confident diagnoses based on the ECG alone.
So it's not just guesswork. These ECG patterns are like a codebook that reveals the secrets of the heart.
Exactly.
That's incredible. But the RVOT isn't the only place these idiopathic arrhythmias can hide, right?
Nope. We also see distinct patterns for arrhythmias coming from near the His bundle, a key part of the heart's electrical conduction system, or from the tricuspid annulus, the ring of tissue around the tricuspid valve.
Okay, so those are some pretty specific locations.
They are. And even the pulmonary artery can be a source, although those can be a bit trickier to tell apart from the RVOT arrhythmias.
So how do they figure that out?
There are subtle clues in the size and shape of those ECG waves, especially in the leads that are looking at the bottom of the heart.
It's amazing how much information is packed into those seemingly simple tracings.
Mm-hmm.
But what about the right ventricular papillary muscles? Those muscles that control the tricuspid valve. They can be sources of arrhythmias too, right?
Absolutely. And this is where things get really interesting. Arrhythmias from the papillary muscles can actually mimic patterns that we see in both right and left bundle branch blocks.
Wait, so the same origin can look like two completely different things on the ECG? How do they make sense of that?
It all comes down to looking at specific leads and the presence of certain features like notching in the precordial leads. For example, lead V1, which sits right over the right ventricle, often shows a distinctive pattern.
So even though the patterns can be complex, there's still a logic to them, a way to decode what the heart is telling us. We've explored the right ventricle pretty thoroughly. What about the left ventricle? Are the patterns equally revealing over there?
The left ventricle definitely keeps us on our toes, but the ECG still provides some pretty valuable clues.
I bet. So we can see specific patterns for arrhythmias coming from the left ventricular outflow tract, or LVOT. I'm guessing that's similar to the RVOT, but on the left side?
Exactly. And we also see patterns for arrhythmias coming from the mitral annulus and even from the papillary muscles of the left ventricle.
Okay, so let's unpack the LVOT first.
Mm-hmm.
Are there different patterns based on where in the LVOT the arrhythmia is coming from?
You bet. We can even differentiate between arrhythmias coming from above the aortic valve, which we call supravalvular, and those coming from below the aortic valve called infravalvular.
So the location in relation to the aortic valve matters. Got it.
Right. And each of those locations has its own distinct ECG signature.
It's like each little nook and cranny of the heart has its own secret code.
You could say that, for example, in the supravalvular region, arrhythmias from the left coronary cusp, which is one of the leaflets of the aortic valve, will often have a specific notched pattern in lead V1.
Okay, so that's a pretty specific clue.
It is. And arrhythmias from the right coronary cusp often show a broader R wave in lead V2.
And those coming from the junction between the two cusps.
Those usually show a QS pattern in V1 with a notch on the downstroke of the wave.
It's amazing how these subtle ECG variations can point to such precise locations. What about those infravalvular arrhythmias? What makes them unique?
Well, they often originate from a structure called the aortomitral continuity, which is basically a fibrous bridge between the aortic and mitral valves. And these arrhythmias typically show a right bundle branch block pattern with positive concordance, meaning all the chest leads have a mainly positive deflection and no S wave in lead V6.
Wow. Okay, those are some clear-cut clues.
Yeah.
So what other locations in the left ventricle can we pinpoint with the ECG?
The left ventricular summit is another interesting one. It's the topmost part of the left ventricle, and arrhythmias from this area often have a delayed intrinsicoid deflection.
Okay, break that down for me. What's intrinsicoid deflection?
It's the time it takes for the electrical impulse to reach the peak of the R wave. And in these summit arrhythmias, that time is delayed because they're originating far from those fast-conducting pathways in the heart.
Got it.
Yeah.
And we can also use that maximum deflection index, or MDI, to differentiate epicardial origins, meaning the arrhythmia is coming from the outer surface of the heart.
Exactly.
Fascinating. Tell me more about the mitral annulus. What kinds of arrhythmias come from there?
Arrhythmias from the front side of the mitral annulus, which we call the anterolateral part, often show a right bundle branch block pattern with a distinctive late notch in the inferior leads. Those from the backside or posteromedial part usually have a right bundle branch block pattern, but with a superior axis and no notching in those inferior leads.
It's incredible how these subtle variations can tell us so much. Now, what about those papillary muscles in the left ventricle? Do they present differently from their counterparts on the right side?
They do share some similarities with their right-sided cousins. Left ventricular papillary muscle arrhythmias also tend to show a right bundle branch block pattern, but the specific features depend on whether the origin is from the anterolateral or posteromedial muscle.
So again, location, location, location.
Exactly.
So the left ventricle clearly has its own set of ECG patterns, just as complex and informative as those from the right ventricle. But I'm curious, how do experts tell the difference between an arrhythmia coming from the left ventricle versus the right ventricle? Are there any telltale signs?
You're asking all the right questions. One helpful clue is the presence of an S wave in lead. It's not a foolproof rule, but it's definitely more commonly seen in left ventricular origins.
Okay, so that's one thing to look for. Yeah. What else?
Another tool we use is the RS ratio in lead V3. If the R wave is smaller than the S wave in V3, meaning the ratio is less than 1, it leans towards a right ventricular origin. If the ratio is 1 or greater, it's more likely coming from the left ventricle.
So it's like a constant game of compare and contrast with these ECG patterns.
And don't forget about the timing of the R wave transition in those precordial leads. It's often earlier in left ventricular origins and later in those right ventricular origins.
Okay, so we've got the S wave in lead I, the RS ratio in V3, and the timing of the R wave transition, all helping us tell left from right. But what about distinguishing between an epicardial origin and an endocardial one? Isn't that a tougher call?
It can be, but we have some specialized criteria to help us out. For example, the presence of what we call a pseudo-delta wave.
A pseudo-delta wave.
Yeah, it's a slurred upstroke at the beginning of the QRS complex, and it often pops up in arrhythmias with a right bundle branch block pattern.
Okay, and why is that significant?
It strongly suggests an epicardial origin.
So it's like a secret code for epicardial.
Exactly. We also pay attention to the intrinsic weight deflection in V2. If it's delayed, it hints at an epicardial origin. And remember that maximum deflection index, or MDI, we talked about earlier? If it's greater than 0.55, that's another red flag for an epicardial origin.
Okay, so those are some pretty specific technical clues, but are there any more visual patterns that might suggest an epicardial origin?
Absolutely. One common finding in epicardial VTs is what we call a precordial pattern break.
Okay, what's that?
It's basically a sudden interruption in the normal progression of R waves across the chest leads. It often signals an epicardial origin because those arrhythmias take a more roundabout way to reach the chest leads, creating these unusual patterns.
It's like the electrical signals are playing hide and seek on the ECG.
In a way, they are. And these patterns can be crucial for guiding treatment.
So it's not just about diagnosing the arrhythmia, but also about planning the best course of action.
Absolutely.
This is all so fascinating. It's amazing how much these subtle ECG variations can reveal. But we've been focusing on arrhythmias in healthy hearts. What happens to these ECG patterns when there's actual heart damage? Do they become more difficult to interpret?
That's a great question, and it takes us to the next chapter in our ECG adventure. When we come back, we'll explore how those patterns change in the presence of structural heart disease. Stay tuned.
I can't wait. And a huge thank you again to the London HeartbeatsZ Academy for providing us with this incredible research. We're so grateful for their dedication to unraveling the mysteries of the heart.
Welcome back. All right, so let's dive into the world of structural heart disease and how it shakes things up on the ECG.
Time to put on our detective hats again.
We'll start with one of the usual suspects, ischemic heart disease.
Ischemic heart disease.
Basically, damage caused by reduced blood flow to the heart muscle, often due to blockages in those coronary arteries.
So those arteries that supply the heart with all the good stuff.
Exactly. And of course, the most dramatic and unfortunately common example of ischemic heart disease is a heart attack.
Ah, yes, the heart attack.
When that happens, it leaves a scar in the heart muscle.
A scar.
And that scar tissue messes with the normal flow of electrical signals, which can lead to, you guessed it, ventricular arrhythmias.
Ooh, I see.
Now, the ECG patterns we see in hearts with these post-heart attack scars can be quite different from those idiopathic arrhythmias we talked about earlier.
Right, because now we're dealing with actual damage to the heart, not just those little electrical quirks.
Exactly. So let's say someone had a heart attack that affected the inferior wall of the heart, the bottom part.
Okay, inferior wall. Got it.
In these cases, the ventricular tachycardia, that rapid heartbeat coming from the ventricles, often originates near the base of the left ventricle,
Near the base.
close to the mitral valve. And on the ECG, we might see a classic right bundle branch block pattern with a rightward axis. And those R waves in the chest leads, they're usually still pretty prominent.
So even with the scar tissue, those R waves are hanging in there.
They are. Now, if that exit site, the point where the abnormal electrical signal breaks out, is more on the septal side of that inferior scar, septal side.
Closer to the wall that divides the ventricles, then the ECG might show a left bundle branch block pattern instead, with a leftward axis deviation.
Okay, so the pattern can flip depending on where that signal's coming from.
Precisely. And if the exit site is way down at the apex of the heart,
The apex, that's the very tip, right?
you got it. Then we often see these deep QS complexes in the leads that look at the bottom and left side of the heart, leads V4 to V6.
So inferior heart attacks have their own set of ECG clues. What about heart attacks that affect the front of the heart? The anterior wall. Are those easier or harder to figure out?
Anterior heart attacks can be trickier because they often involve a larger area of damage,
Oh, that makes sense.
which can make those ECG patterns more complex to interpret.
So more pieces to the puzzle.
But there are still some helpful signs we can look for.
Hmm.
For instance, a left bundle branch block pattern with a leftward axis usually points to an origin in the bottom front part of the heart, what we call the inferior apical or septal region of the scar.
Okay, so the location of the scar still matters. Absolutely.
Huh.
And if we see a negative concordance in the chest leads,
Negative concordance.
meaning all the chest leads have a mainly negative deflection along with those deep QS complexes in V4 to V6, it's a pretty good bet the arrhythmia is coming from the very apex of the heart.
So even with larger scars, the ECG can still give us a pretty good idea of where the problem is coming from.
That's the power of the ECG.
Now, we talked about those papillary muscles earlier, those little muscles that help control the valves.
Right, the ones that can cause arrhythmias even in healthy hearts.
Exactly. Can they also cause problems after a heart attack?
Absolutely. In fact, post-infarction ventricular tachycardia coming from the papillary muscles can mimic the patterns we see in those idiopathic cases.
So those patterns can be pretty misleading.
They can. We often see a right bundle branch block pattern with a late transition from R to S waves in the chest leads.
Okay, and how can we tell which papillary muscle is involved?
The axis can help us out. A superior axis suggests the problem is coming from the infraseptal papillary muscle, while an inferior axis points to the anterolateral muscle.
So the axis gives us that extra piece of information.
It does.
Okay, we've covered a lot of ground with ischemic heart disease, but heart damage isn't always caused by those blocked arteries, right? There are other ways the heart muscle can become weak or damaged.
You're right. There's a whole other category, what we call non-ischemic cardiomyopathies,
Non-ischemic cardiomyopathies.
where the heart muscle itself is weakened or damaged for various reasons.
Okay, and can those also lead to ventricular arrhythmias?
They can, and they often do, each with their own unique ECG signature.
So we're going even deeper into the ECG codebook.
Exactly. Let's start with dilated cardiomyopathy.
Dilated cardiomyopathy.
This is where the heart chambers become enlarged and weakened.
I've heard of that one. What does it look like on the ECG?
Well, it's interesting because the ECG patterns can actually evolve as the disease progresses.
Oh, that's tricky.
It is. In the early stages, when the scar tissue is mainly at the base of the heart, we might see large R waves in the precordial leads during a ventricular tachycardia.
Large R waves. Okay.
But as the disease progresses and that scarring becomes more widespread, those R waves start to shrink.
They shrink.
And we might see what we call poor R wave progression.
Poor R wave progression.
Meaning, the R waves don't get progressively larger as we move across the chest leads.
Interesting. So the ECG can actually tell us how severe the dilated cardiomyopathy is.
It can. It's a sign of more significant damage and often correlates with weaker heart function, what we call heart failure.
So the ECG is not just about diagnosing the arrhythmia, it's also about assessing the overall health of the heart.
Exactly. And because that scar tissue in dilated cardiomyopathy is often scattered throughout the heart muscle, those QRS complexes, those main spikes on the ECG, tend to be wider than normal.
Wider than normal.
And they might even show some notching or fragmentation.
Notching and fragmentation.
Little bumps and dips in the waveform.
So it's not just the size of the waves, but also their shape that matter.
Exactly. It's like the electrical signal is encountering roadblocks and detours as it tries to navigate through that damaged tissue.
It's like trying to drive through a city during rush hour.
A very bumpy ride. And if the His-Purkinje system, that specialized electrical conduction system within the heart, is affected, we might see even more unusual ECG patterns.
Okay, so dilated cardiomyopathy definitely keeps those cardiologists on their toes. Are there any particular types of arrhythmias that are more common in this condition?
One common culprit is what we call bundle branch reentry, or BBR for short.
BBR. Got it.
This happens when the electrical signal gets trapped in a loop within those damaged bundle branches.
Trapped in a loop.
And it can cause really rapid heartbeats that can be quite dangerous.
Sounds serious.
Yeah.
How does BBR look on the ECG? Is it easy to spot?
It can actually mimic the pattern we see during normal sinus rhythm, especially if the person already has a left bundle branch block. But sometimes BBR can manifest as a right bundle branch block pattern with some additional features.
So it can be a bit of a chameleon.
It can, and in rare cases, we might even see intravascular reentry where the signal gets trapped within one of the fascicles, those smaller branches within the bundle branches.
Okay, so we're getting into some pretty intricate details here.
We are, but these details can be crucial for making the right diagnosis.
So dilated cardiomyopathy can really create some challenging ECG puzzles. What about arrhythmogenic right ventricular cardiomyopathy? That's a mouthful.
It is, but the name pretty much sums it up. It's a type of cardiomyopathy where the muscle of the right ventricle is gradually replaced by fat and scar tissue.
Fat and scar tissue instead of muscle.
Exactly, making it prone to those pesky arrhythmias.
And I'm guessing the ECG looks different in this case.
It does. Since the right ventricle is the main problem here, the ECG often shows a left bundle branch block pattern, especially in lead V1, which sits right over the right ventricle.
So in this case, the left bundle branch block is actually telling us something about the right ventricle.
Precisely. And the axis, that direction of the electrical signal, can give us some hints about where in the right ventricle that abnormal rhythm is coming from.
More clues to decipher.
And because the scarring in this condition can be pretty extensive, those QRS complexes are often very wide.
Okay, so wide QRS complexes, a left bundle branch block pattern, all signs pointing to arrhythmogenic right ventricular cardiomyopathy.
You got it.
What other non-ischemic cardiomyopathies can we identify based on ECG patterns?
We often see distinct patterns in conditions like sarcoidosis, Chagas disease, and hypertrophic cardiomyopathy.
Okay, let's break those down one by one.
Yeah.
What about sarcoidosis? What kind of ECG pattern would we expect to see there?
In sarcoidosis, we often see a left bundle branch block pattern with a specifically delayed downstroke in the QS complex in lead V1. It's a telltale sign of right ventricle involvement, which is often a primary target in cardiac sarcoidosis.
So that delayed downstroke is the key.
It is.
What about Chagas disease?
Chagas cardiomyopathy typically presents with a classic right bundle branch block pattern and a rightward axis. This is because the damage is usually concentrated in the inferior lateral wall of the left ventricle.
Okay, so that makes sense given where the damage is located.
It does.
And finally, hypertrophic cardiomyopathy.
In hypertrophic cardiomyopathy, the ECG can show a variety of patterns, but one classic finding is small R waves, or even QS complexes in the precordial leads, along with a superior axis.
And why is that?
It's because those arrhythmias in hypertrophic cardiomyopathy often come from the thickened apex of the heart, the very bottom tip.
So each of these cardiomyopathies leaves its own mark on the ECG.
They do. It's like their own unique fingerprint.
We've talked a lot about arrhythmias originating from within the heart chambers, what we call endocardial arrhythmias. But what about arrhythmias that come from the outer surface of the heart, the epicardium? Can the ECG help us with those as well?
It absolutely can. And recognizing those epicardial arrhythmias is super important because they often need a different treatment approach.
So the ECG isn't just about diagnosing the arrhythmia, it's also about guiding the treatment strategy.
You got it. In fact, there are specific ECG criteria that can help us predict whether or not we'll need an epicardial approach during catheter ablation.
Catheter ablation, that's the procedure where they use heat or cold to destroy the tissue causing the arrhythmia, right?
Yeah, exactly. And if the arrhythmia is coming from the epicardium, we might need to access that outer surface of the heart during the procedure.
Which makes sense.
So let's talk about those epicardial ECG clues. What should we be looking for?
Lay it on me.
One of the classic findings is the presence of that pseudo-delta wave we talked about earlier.
The pseudo-delta wave is back.
It is. Remember that slurred upstroke at the beginning of the QRS complex?
Right, often seen in arrhythmias with a right bundle branch block pattern.
Exactly. Well, that pseudo-delta wave is like a flashing neon sign telling us the arrhythmia is likely coming from the epicardium.
Okay, so that's one thing to look for. What else?
We also pay attention to the intrinsicoid deflection in V2.
Intrinsicoid deflection again.
Remember, that's the time it takes for the electrical impulse to reach the peak of the R wave.
Right, and if it's delayed?
If it's delayed, it hints at an epicardial origin.
Okay, so that's another clue. And what about that MDI, the maximum deflection index?
Ah, yes, the MDI. An MDI greater than 0.55 is a strong predictor of an epicardial origin.
So we've got the pseudo-delta wave, the delayed intrinsicoid deflection, and the MDI all pointing us towards the epicardium. But are there any other clues, any other patterns that might help us out?
Absolutely. For example, an initial Q wave in lead, I followed by an R wave, especially in right bundle branch block VTs with an inferior axis, often points to an epicardial origin on the anterior wall of the right ventricle.
Okay, so even the presence or absence of certain waves in specific leads can be super informative.
It's all about the details.
What about the inferior wall of the right ventricle? Any clues for epicardial origins there?
If we see an initial Q wave in the inferior leads followed by an R wave, it often suggests an inferobasal right ventricular exit site, which again might need an epicardial approach.
So it seems like those Q waves can be pretty telling.
They can be.
This is all so incredible. It's like we're cracking the code of the heart with every new ECG pattern we learn about.
It is quite amazing how much information we can get from those squiggly lines.
But I have to admit, it's a lot to keep track of. How do cardiologists make sense of it all?
Well, it does take practice and experience to master the art of ECG interpretation.
Years of training and studying, I imagine.
But remember, the goal isn't to memorize every possible pattern.
So it's not about rote memorization.
It's about understanding the principles behind those patterns and how they relate to the heart's anatomy and any underlying disease.
So it's more about understanding the language of the ECG rather than just memorizing a dictionary.
Exactly. And the better you understand that language, the better you can interpret the stories the heart is telling.
Beautifully put. It's like learning to read the heart's diary.
In a way, it is.
Okay, before we move on, I want to take a moment to thank the London HeartbeatsZ Academy again for providing us with this amazing research. Their work is truly groundbreaking.
I couldn't agree more.
So we've seen how the ECG can help us pinpoint the origin of ventricular arrhythmias in both healthy hearts and those with structural damage. We've explored how different conditions like heart attacks and cardiomyopathies can affect those ECG patterns. But there's one more piece of the puzzle we need to address.
And what's that?
The concept of differential diagnosis.
Ah, yes, the art of distinguishing between different conditions that can look similar.
Exactly. Because we've seen how various types of ventricular arrhythmias can have overlapping features on the ECG.
It's true. Those patterns can be tricky sometimes.
So how do cardiologists use the ECG to tell them apart and arrive at the correct diagnosis?
It's like solving a mystery, piecing together clues from the ECG, the patient's history, physical exam, and other tests.
So it's not just about the ECG alone.
It's about looking at the whole picture.
Okay, well, let's start with one of the most fundamental distinctions differentiating between arrhythmias coming from the left ventricle versus the right ventricle.
Our left versus right.
We talked about some clues earlier, like the S wave in lead I and the RS ratio in lead V3. But are there any other tricks of the trade that cardiologists use to tell left from right?
One helpful feature is the actual shape of the QRS complex in leads V1 and V2.
The shape of the QRS.
Those leads that are placed over the right ventricle. In left ventricular origins, those leads often show a taller R wave, sometimes even a dominant R wave, while in right ventricular origins, they usually have a deeper S wave or even a QS pattern.
So it's all about comparing those R and S waves in those key leads.
Exactly. What about the transition point?
The transition point. Remind me what that is again?
It's the point in the chest leads where the QRS complex goes from mainly negative to mainly positive.
Right, right.
In left ventricular origins, that transition tends to happen earlier, maybe in lead V3 or even V2. But in right ventricular origins, it's usually later, often in V4 or even V5.
So the timing of that transition can give us a clue as well.
It can.
Okay, so we've got those R and S waves in V1 and V2, the transition point, and of course the S wave in lead I and the RS ratio in V3, all helping us differentiate between left and right. What about telling an epicardial origin from an endocardial one? We talked about some specific criteria earlier, but are there any other hints we can get from the ECG?
One helpful sign is the presence of what we call a precordial pattern break.
A precordial pattern break.
This refers to a sudden change in the shape of the QRS complex across the chest leads. Often there's a loss of the R wave in one or more leads, followed by its reappearance in the next leads.
So it's like a sudden interruption in the normal flow of the ECG pattern.
Exactly. And this pattern break often signals an epicardial origin,
Why is that?
because those epicardial arrhythmias often take a longer, more complicated route to reach those chest leads, creating those unusual patterns.
So the electrical signals are taking a detour.
You could say that. And those detours can be really helpful for us in figuring out where the arrhythmia is coming from.
It's amazing how much we can learn from paying attention to those subtle variations in the ECG. It's like reading a detective novel looking for those hidden clues.
It really is. And with every clue, we get closer to solving the mystery of the arrhythmia.
Well, I don't know about you, but I'm feeling like I could read an ECG now.
I think you're well on your way.
It's really amazing how much we can learn from those little squiggles.
It is. The heart never ceases to amaze me.
And speaking of amazing N, we have to give another huge thank you to the London HeartbeatsZ Academy for giving us the research for this deep dive. Their work is truly incredible.
Absolutely. They're real pioneers in the field of cardiology.
So as we wrap up this episode, I'm left with this feeling of awe at how complex the heart is and how powerful the ECG is as a tool.
It really is a remarkable tool. I mean, from just 12 leads, we can gather so much information about the heart's anatomy, its function, and even underlying disease.
It's like a window into a heart's electrical soul. It makes you wonder, if we can pinpoint the source of a heart rhythm problem from just external signals, what other mysteries of the body could we unlock in the future?
That's a great question. The potential is definitely there. I mean, imagine being able to diagnose neurological disorders or even track the progression of cancer just by looking at electrical signals.
It's mind-boggling.
It really is. The possibilities are endless.
Well, this deep dive has been a fantastic reminder of just how powerful scientific curiosity is. So to our listeners out there, keep asking those questions, keep exploring, and keep diving deep into the world around us. You never know what incredible discoveries are waiting to be uncovered.
Well said. Keep those heartbeats strong and steady, everyone.